Assalamu alaikum everyone. My name is Syed Roshan, roll number EP1770153, group number 7. The topic of my assignment is viral infections and the subtopic is hantavirus infections. Now, what is hantavirus infections? Hantavirus basically belong to the family Bunia viridae. It is found globally causing serious type of diseases which can be fatal, rating up to 45%. It is estimated that there are 1 lakh to 2 lakh infections occur worldwide annually. The early symptoms of this virus infection includes fatigue, fever, and muscle aches, especially in the large muscles group thighs, hips, backs, and sometimes shoulders. These symptoms are universal. Everyone is prone to it. Now, the sources of hantavirus and viruses. There are several distinct viruses, each associated with a specific rodent. These infections in rodent are lifelong without deleterious effects. Hantavirus is found in the urine, saliva, or droppings of the infected mice and some other wild rodents. Now, the transmission of hantavirus. As you can see, I have shown a flow cycle of transmission of hantavirus. So basically, there is a chronic infected rodent which infects healthy mice, and from that mice droppings, basically that is urine or some type of excretion, the patient through open skin wounds or inhalation is infected from this virus, or basically the transmission of hantavirus is through this process. Now, the diseases caused by hantavirus infections. So the infection with any hantavirus is associated with the geographic distribution of rodents and nature of viruses. There are basically two types of diseases: hemorrhagic fever with renal syndrome, HFRS, and the second one is hantavirus pulmonary syndrome, HPS. Now the management and preventions of this virus. Hemorrhagic fever and the renal failure are managed with supportive treatment, effective rodent controlling from surrounding, the protection from rodent dropping and contaminated material. This point is very much important. The maintenance of adequate oxygen, supporting hemodynamic functioning, and the use of antiviral drug ribavirin is some beneficial in most of the cases. Now moving forward to the case study. Uh, the case study is basically from subcontinent. A 36-year-old Sri Lankan Sinhalese man from Kandy, Sri Lanka, who was presented to a tertiary care hospital with a 3-day history of an acute febrile illness. He had been in apparently good health and working as a farmer involved in paddy cultivation. In the paddy cultivation, remember, there is a lot more of chances in contraction or in coming contact with the rodents, specifically the chronic affected rodents. 3 days prior to the admission, he developed high spiking fever with chills and rigors associated with severe arthralgia and myalgia. He could not mobilize due to severe muscle cramps in lower limbs. He developed shortness of breath at a rest with a non-productive cough 1 day prior to the admission and was anuric for 12 hours prior to the hospital admission. His past medical history was unremarkable and there was no significant medical illness in his family, although he was an occasional ethanol consumer and did not smoke tobacco. Now, the clinical assessment. On admission to the emergency unit, we found an averagely built man with a body mass index of 24 who was in severe distress and pain. He was severely dehydrated too. He had mild enteritis with injected and stuffed conjunctiva. He had a temperature of 39.5 degrees centigrade with a warm peripheries. His pulse rate was 140 per minute with a blood pressure of 80/40 mmHg, and he had a marked postural symptom on attempting a standing blood pressure. He was dyspneic with a respiratory rate of 32 cycles per minute on air saturation of 90%. It is improved with 10-liter oxygen via face mask. On examination of his lung fields, he had bilateral coarse separations. He had a 3 centimeter hepatomegaly, which was tender without palpable spleen of flank dullness. Although he was agitated and in distress, he was oriented in time, place, and person with normal neurology. Now, the treatment plan. Patient was immediately moved to a high dependency unit and oxygen was given via face mask. He had 50 ml of concentrated urine after catheterization. After fluid resuscitation of 1.5 liter of crystalloids, he was started and intravenously administered noradrenaline as his blood pressure remained low. Intravenously administered cefotoxamine was orally administered. Doxycycline was prescribed after taking blood cultures. Acidosis was corrected with 8.4 sodium bicarbonate and the N-acetylcysteine NAC infusion was started considering his elevated transaminases. Now, hypokalemia was corrected with intravenously administered potassium chloride. He was given 1 gram of intravenously administered methylprednisolone. After 3 days of illness, our patient was clinically improved with less myalgia. Now, over the subsequent 5 days, his clinical condition gradually improved with gradual normalization of biochemistry of his body, with improved blood pressure, rate, and oxygen requirement. Although methylprednisolone 1 gram continued for 3 days and intravenously administered cefotoxamine and orally administered doxycycline for a total of 7 days. In the end, he was discharged after an uneventful recovery on day 7 of hospital admission. So, this was my case study and the treatment plan. Hope you all liked it. Thank you so much.